Thank you, Nelson. Good evening, everyone. Welcome to the webinar today. Our topic is on self-injurious behavior in children with neurodevelopmental disorders. My name is Judy Machuka. I'm a psychologist at Kenyatta National Hospital, and I'll be moderating this evening. So I would like to introduce our panelists. There are two of them. And one is Dr. Amolo, who is a consultant pediatrician at Kenyatta National Hospital, currently pursuing a fellowship in pediatric neurology in South Africa. And she hopes to improve neurological care of patients attending public hospitals. We also have another panelist, that is Dr. Hassan, who is a consultant pediatrician currently pursuing a fellowship in pediatric neurodevelopment in South Africa. And today she will be joining together with Dr. Amolo. She's passionate about long-term care of patients with neurodevelopmental disorders and I don't know whether you'd like us to handle the questions all together at the very end. Maybe you can share as you take it up. So, Dr. Amolo, you may take it away. Thank you.
Thank you, Judy, for that great introduction. So today I will be discussing self-injurious behavior in children with neurodevelopmental disorders. I hope you can all hear me clearly. So I thought this would be an interesting topic to discuss because it's a challenge that many patients battle with. And usually the parents are quite frustrated and are often desperately trying to seek a solution for this very challenging problem. So I thought it would be interesting to highlight about self-injurious behavior, and I will have input from Dr. Hassan, and I know Judy will also be available to give us input as a psychologist. So this is a picture of Katie Price. Katie Price is a famous actor in the UK. She has a son who suffers from Prader-Willi syndrome. Prader-Willi syndrome is a neurodevelopmental disorder. It's usually characterized by children who have intellectual disability. They have hyperphagia, which is a great desire to eat. They are quite hypotonic at birth. They have hypogonadism. And one of the characteristic features that these children have is that they have self-injurious behavior. And this usually occurs when you deny them food. So Katie Price has documented the challenges that she's had having a child who has Prader-Willi syndrome. And she has told us of how sometimes he goes into violent fits and rages when you deny him food. And this has forced them to lock the fridge sometimes or even lock the kitchen so that he doesn't have access to food. And usually when he's denied food, he can bang himself, hit himself, slap himself. And in fact, this has forced her to take him to an institution for the sake of his own safety. So in Kenya, we don't hear much about children who have self-injurious behavior, and it makes you wonder whether we are missing out or where these parents are turning for help. So what is self-injurious behavior? It's a class of behaviors that are often highly repetitive and rhythmic that result in physical harm to the individual displaying the behavior. These are non-normative behaviors, meaning they are not normal behaviors, and they're usually performed with the intent of physical harm, but not really with the intent of dying. They include various behaviors such as head banging, self-biting, self-hitting, face slapping, pulling out the hair, or even poking their eyes. And it can actually result in very severe injury. Some children with self-injurious behavior demonstrate what we call self-restraint. Self-restraint is an attempt to prevent this self-injurious behavior. For example, some of these children will sit on their hands or hold their arms behind their back so that they do not have self-injurious behavior. And some individuals would usually place themselves in a position of self-restraint to avoid performing this self-injurious behavior. From the picture above on the right, you can see a girl who suffers from hair pulling, and you can see it's actually resulted in alopecia. And the picture below is of a boy who has autism, who's demonstrating self-biting behavior. So self-injurious behavior usually occurs in two groups of patients. We have those who have psychiatric conditions, such as eating disorders. We all know about bulimia, where patients usually eat and then they self-invoke vomiting so that they don't gain weight. Anorexia, where patients deny themselves food. Depression and those with borderline personality disorders often demonstrate self-injurious behavior, such as the girl at the bottom who cut themselves with a razor blade. It can also occur in patients who have neurodevelopmental disorder. Most of us are familiar with this behavior in patients with autism, such as the boy in the middle who's demonstrating head banging. But it can also occur in other neurodevelopmental disorders, such as Lashline Syndrome. Lashline Syndrome, which I'll discuss a bit later, can have quite severe self-injurious behavior, such as the teenager's hands on the right lower area, where you see that this teenager has actually bitten off parts of his fingers. It can occur in other conditions, such as Duchenne, Fragile X syndrome, as well as Rett syndrome, which I'll touch on. So what's the prevalence of self-injurious behavior? It's quite common in children with neurodevelopmental disorders. My focus today will be on children with neurodevelopmental disorders and not those with psychiatric conditions. It can be observed at any age, as early as 6 months of life, and it can actually be lifelong. And you can imagine how frustrating this can be for the primary caregivers. The prevalence and expression of self-injurious behavior is variable and usually depends on a number of factors which I'll discuss, such as the specific condition that the child has. And the prevalence can be as high as 50% among children with autism spectrum disorder. About 14% usually exhibit severe self-injurious behavior in which the behavior results in functional impairments or life-threatening injuries. The prevalence of self-restraint, which I talked about in those with self-injurious behavior, is quite variable, ranging from about 46 to 76%. Management, as you can only imagine, of self-injurious behavior is quite complex, especially in the African setting. And this is made more difficult by the fact that there's very little high-quality data on the right approach to manage these children. So what's the impact of self-injurious behavior? You can imagine what a profound impact it has on the patient himself, because we've mentioned it can cause quite severe injuries. The caregiver, we find that oftentimes parents have to miss out on many days of work. Some parents have to, some families you find that one parent has to quit their job so that they can be the sole provider. You can imagine how difficult it is expecting a nanny to take care of your child who engages in self-injurious behavior. So it can have quite a profound impact on the family setting, as well as the clinicians, because of lack of clear guidelines on the correct approach for these patients. And you find that families are often desperate for relief and solutions. We've all heard of many families of children with autism wanting to go to India for stem cell transplants because they're so frustrated and they just cannot get a solution for this problem. And it's commonly reported as one of the most negative influences on the quality of life. It's actually been found that children who engage in self-injurious behavior, their families usually have the highest rates of divorce. Clinical, social, financial, and emotional burdens are quite high. Parents often have to spend large amounts of money looking for solutions. It's a very emotional condition to deal with, not just for the patient, but for the family, as well as for the siblings. And children with self-injurious behavior risk interfering with the acquisition of adaptive skills and serious or permanent injuries. So it has quite a profound impact on everyone who comes into contact with these children. And you can imagine also these children who go to school, the teachers, the students who are with them often have to figure out a way of dealing with children who perform self-injurious behavior. So what is the etiology? It's multifactorial. There's a genetic predisposition, medical causes, regulation of sensory and emotional states, communication and attention seeking, disruption of pain pathways and over-arousal. And I will discuss each of these in depth, beginning with genetic predisposition. So there are certain genetic syndromes that are known to be associated with self-injurious behavior. Most of us are familiar with pervasive developmental disorders, such as children who have autism spectrum disorder, Asperger's, or pervasive developmental disorders not otherwise specified, or what we call Rett syndrome. There are other conditions such as Lashline Syndrome, Prader-Willi syndrome, SmithMagena Syndrome, Cornelia de Lange, or Fragile X syndrome. Unfortunately, many of these conditions in the Kenyan setting can go undiagnosed because of lack of awareness among families, among clinicians, and lack of genetic tests that can help us confirm this diagnosis. The severity of self-injurious behavior is dependent on the specific condition that the child has. For example, in patients with Lashline syndrome, they can have very severe forms of self-mutilation, like biting off their lips and biting off their fingers, as we've seen in the diagram that I showed. So I'll discuss a little bit about each of these genetic conditions, beginning with autism spectrum disorder. This is a condition that is being recognized more and more in Kenya, and it's usually characterized by persistent deficit in social communication and social interaction. Majority of the times, a parent will bring their child to hospital because they think that the child is deaf. The parent will usually wonder why when she calls the child fails to respond. The child does not have eye contact. These children also engage in restricted, repetitive patterns of behavior, interests, and activities. They like to do the same thing over and over and over again. And you'll find a lot of times these patients will have behaviors such as hand flapping, head banging. You may find they also have echolalia, where they tend to repeat what they hear on TV. Like if they are used to maybe Baby Shark, all day inappropriately, they will be singing Baby Shark. The symptoms usually must be present in early development, and symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. And these disturbances are not better explained by intellectual or global developmental delay. The global prevalence of autism spectrum disorder is now around 1 to 2%. And as I mentioned earlier, it's being recognized more and more in Kenya. It's estimated that 1 in 160 children worldwide have autism spectrum disorder. It has heterogeneous clinical presentation with severity ranging from mild to disabling. Usually in mild, it's classified as ASD1, and the more severe phenotype would be ASD type 3. This one usually requires diagnosis by either a developmental specialist or a neurologist, and we have excellent neurologists and developmental specialists in the country now who are recognizing this condition more and more. The etiology of autism spectrum disorder is unknown. It's thought to have a genetic component as well as environmental components and neurobiological factors. Some of the self-injurious behaviors that children with autism engage in include head banging. This commonly is associated with, for example, the child may have a headache, a toothache, a sinus infection, or another form of infection, and their way of communicating, because you find that many of these children are unable to they do not have speech and language. So they would communicate by engaging in a self-injurious behavior like head banging or head hitting or slapping. Eye poking can be done in those who have eye pain or visual loss. Gum or tooth digging or banging can occur in those who have dental pain, gingivitis. Scratching and skin picking can occur in those who have skin disorders like allergies, eczema, or more severe infections like scabies and fleas. Finger and toenail biting or picking can occur in pain. Kicking or stomping can occur in conditions such as restless leg syndrome or leg pain, and rumination can occur in those who have reflux or eosinophilic esophagitis. And these have the potential to have very severe impact, such as blindness from eye poking, fractures and bruises from kicking and stomping, or even detachment of the retina, abrasion, or contusions. So we have other conditions where patients engage in self-injurious behavior, such as Fragile X syndrome. This is usually caused by a mutation in the X chromosome that disrupts what we call the Fragile X mental retardation protein. This condition is usually characterized by what we call anticipation. Anticipation means that in each subsequent generation, the symptoms appear earlier and earlier. So you may find that it may not be recognized, for example, in the father, but in the children who the father has, the condition usually is more severe. So with each generation, you have a more severe phenotype. Children will characteristically have certain distinct features, such as large prominent ears, an elongated face, large testes, or what we call macroorchidism, a prominent forehead, cognitive delay. So for example, if you're sitting in your clinic and a parent comes with a complaint of the child having self-injurious behavior, see that this father has a large head, prominent ears, he has cognitive delay, then you examine the child looks exactly like the father and he's displaying a more severe phenotype, it can raise the suspicion of Fragile X syndrome, and being an X-related disorder, it affects only boys. Patients will usually have aggression, impulsivity, anxiety. Autism may occur in these patients, and 17 to 70% of patients with Fragile X syndrome will usually have self-injurious behavior, which is characterized by hitting themselves, biting themselves, or scratching themselves. Another condition that can have self-injurious behavior is Prader-Willy syndrome. I've alluded to this earlier in the famous actress Katie Price, whose child has Prader-Willy syndrome. This is usually caused by a mutation in chromosome 15, the long arm position 11 to 13, and usually it's inherited from the father's DNA. Clinically, these patients have what we call the 4HO syndrome, where they have hypotonia, meaning they're very floppy, hypomentition, meaning they have intellectual disability, hypogonadism, which would be the opposite of Fragile X syndrome, where they have hypergonadism. They're very obese, and this is partly due to the hyperphagia. We mentioned earlier that these patients usually have an intense desire to eat, and when you deny them food, they can engage in self-injurious behavior. They're of short stature, they are obese, and they have behavior and psychiatric conditions such as aggression and depression. They engage in self-injurious behavior such as nail biting, hair pulling, and as I mentioned, the triggers are usually food denial. We have Rett syndrome, which is classified under pervasive developmental disorders where autism falls. It's usually caused by a mutation in what we call the MECP2 gene and leads to abnormal brain development. It usually affects girls, and these girls would usually be normal, and then they have a sudden regression in previously acquired skills, like they may stop talking, they suddenly have microcephaly, where their head becomes smaller and smaller as they grow. They have repetitive hand stereotypic movements, such as wringing of their hands or flapping of their hands. They may have an ataxic gait, which is a wide, broad-based gait like a drunkard, intellectual disability, and they demonstrate autistic-like behaviors. 50% of patients with Rett syndrome demonstrate self-injurious behavior, such as hitting their mouth or hand biting. Another genetic condition that can present with self-injurious behavior is what we call Cri-du-Chat syndrome. It's usually caused by a deletion in chromosome 5, the short arm. These patients have a characteristic cat-like cry. They have intellectual disability, limited language development, sleep disturbances, hypersensitivity to auditory stimulation. So for example, if you bang the door, they are very hypersensitive. They may have vomiting. And when you look at their faces, as you can see on the picture, they have a small chin, what we call micrognathia, a large tongue. Most of them have a cleft lip palate and low set ears. About 76 to 92% of patients with cri du chat demonstrate self-injurious behavior, such as head hitting, biting, or scratching themselves. Another condition is SmithMagena Syndrome, caused by deletions in the RII1 gene. Patients will have characteristic facial appearance, such as brachycephaly, mid-facial hypoplasia. They have a hoarse voice, speech delays, psychomotor and growth delays. They're very floppy or hypotonic. They have behavioral problems as well as cutaneous features. Nearly all patients with SmithMagena syndrome demonstrate severe self-injurious behavior, including biting themselves, hitting themselves, head banging, picking at their fingernails, and they demonstrate insertion of foreign objects into orifices such as the genitalia, their mouth, their ears, and their nose. We also have a condition called Cornelia de Lange syndrome. It's caused by certain mutations in the NIPBL gene. They usually have multiple behavioral and developmental syndromes. They have limb abnormalities such as short limbs, growth delay, cardiac and genitourinary anomalies, and short-sighted. They demonstrate certain self-injurious behaviors, the most classic being slapping themselves on the face, self-biting, as well as skin picking. And then we have Lashline Syndrome, which I had alluded to earlier. It's a rare inborn error of metabolism. It's caused by a mutation in the HPRT gene. Actually, I remember in one of the pediatric groups, they once had a child who had the typical features of self-injurious behavior with the child had bitten off the lower lip and also was biting off the fingers. It's usually caused, this self-injurious behavior is thought to occur due to hyperuricemia. They have weird dance-like movements of the hands, what we call choreothetosis. They have intellectual disability, and they're very aggressive towards others. And the self-injurious behavior that they demonstrate is lip biting, finger biting, head banging, or banging of the arms and the legs. So this is just to emphasize to you that it's not just patients with autism spectrum disorder who demonstrate aggressive self-injurious behavior. As clinicians, we need to be aware that there are other conditions. And if you're seeing a patient in your clinic and you see certain characteristic features, then you must refer them to your neurologist, your endocrine specialist, or your developmental specialist, so that they can arrive at a diagnosis, because a few of these conditions have specific treatment, such as Lashline syndrome, where you can give them allopurinol to reduce the uric acid, and this can lead to reduction in the self-injurious behavior. So aside from medical causes, genetic causes, medical causes can also cause self-injurious behavior. Sleep issues, for example, are most strongly and consistently associated with self-injurious behavior. And this has been studied well in patients with autism spectrum disorder, who we know usually have sleep problems, delay in initiation of sleep. They have what we call a delay in the circadian rhythm. So you find they have a lot of sleep interruption and sleep fragmentation. They sleep late, they wake up early. By 3 a.m., this child is awake. The mechanism is poorly understood of how self-injurious behavior occurs in patients who are sleep deprived, but improvement in sleep has led to less self-injurious behavior in some children. For example, in children with autism who improve sleep by giving them melatonin, they demonstrate less self-injurious behavior. So it's very important to look at sleep hygiene. Neurological conditions are also associated with self-injurious behavior, and it's more common in those with neurodevelopmental disorders and associated comorbidities, such as seizures. Comorbid medical conditions, such as patient who is in pain, who is constipated, who has a headache, a patient who has menstruation, depression, or urinary incontinence, is more likely to have self-injurious behavior. And a lot of times it's because these children are unable to communicate. So they get very frustrated and they resort to self-injurious behavior as a way of bringing attention to the primary caregiver. And this will prompt the primary caregiver to take them to a clinician to assess as to what the problem could be. Self-injurious behavior also occurs as a way of regulating sensory or emotional states. Sensory abnormalities cause a heightened negative reaction that's hyper or over responsiveness, or a decrease or slower reaction that's hypo or under responsiveness to stimuli. The behavior range from extreme reactivity or avoidance to apparent obliviousness or indifference. An example I'll give is patients who have autism spectrum disorder. Most parents will usually come in with the complaint of when the child hears a vacuum or hears a kettle whistling, they cover their ears as though irritated. Or sometimes when the TV goes on suddenly, they get very irritated and cover their ears. And this is usually because they have a heightened negative reaction and they're over-responsive. Sometimes under-responsive can be demonstrated in the example I alluded to earlier. In an autistic child, the parents will come in and say, I keep calling the child, but the child just seems oblivious and indifferent. They just continue doing what they're doing. And that is usually hypo or under responsiveness. In the cases of hyper-responsiveness, sensory input may be perceived as being highly unpleasant. That kettle is very irritating to the child. They don't want to hear that vacuum, or even painful in many individuals with ASD. Early theories hypothesize that individuals with neurodevelopmental disorder use self-injurious behavior to regulate sensory input. That is, to block out excessive stimulation. So when they hear the vacuum, they suddenly start scratching themselves as a way to regulate the sensory input or to increase arousal when understimulated. Self-injurious behavior could serve in some cases as a communication that sensory experiences may be intolerable. So they're trying to grab the attention of the adults. Self-injurious behavior can also occur as a way of communication or attention seeking. Self-injurious behavior is more frequently seen in individuals with neurodevelopmental disorders who lack functional communication. And it leads to socialization deficits and a lack of stimulation from the environment. Resulting social and environmental isolation promotes expression of self-injurious behavior as a way of communicating. For example, if Peter is sitting in a classroom and they're about to perform difficult arithmetics, and Peter does not like difficult arithmetics, so when he sees that the teacher bring the book to him, he can suddenly start banging his head on the box, on the desk, so that he can escape from that particular activity because he's non-verbal. And when he starts banging his head on the table, the teacher may withdraw him from the classroom. And in that way, he's able to escape doing the difficult mathematics. And because he was unable to communicate, that is his way of communicating. So as I've said, it's a means of escaping non-preferred activities, or it's a means to gain access or attention to preferred activities. For example, if Jane is watching cartoons and her parents suddenly come into the room, they want to watch news, they change the channel, Jane may suddenly start scratching herself and screaming, and the parents, in order to prevent her from doing this, they'll quickly put back the cartoon in order to calm Jane down. And this is an example of positive reinforcement. And sometimes self-injurious behavior is done for its own consequences, what we call automatic reinforcement. Attention and escape are the most commonly identified functions of self-injurious behavior. So self-injurious behavior also occurs as a disruption of pain pathways. So pain, it's a complex biological phenomenon that has both sensory and emotional components. Pain acts as a warning system to protect us from further harm and allow injured tissue to heal. It also evokes behavior to bring about relief or comfort. Nociceptors in the skin and internal organs usually carry signals to our spinal cord through the dorsal horn, and where they communicate with interneurons, and this play a role in either inhibitory or excitatory role. Self-injurious behavior likely involves alteration in circuits that connects the multiple brain regions and dysregulation of various neurotransmitters such as opioids and serotonin. we find that patients who have neurodevelopmental disorders may often have a disruption of pain pathways. And that's why you might actually find sometimes a child with perhaps autism will go and be playing with a hot pan, and they will not actually realize that the pan is hot, and they'll keep touching it, and you actually find that they end up having burn marks. So this is because they have a disruption in their pain pathway. Another example is sometimes you find that they actually keep scratching themselves. And when the parents comes, you can see that they have obvious injury, but they keep going on and on and on. For the normal individual, if you have any slight pain, you usually stop doing that particular activity that causes the pain. So theories of pain and self-injurious behavior. There was a study that was done by Sandman et al. Who proposed an opiate hypothesis of self-injurious behavior in patients with autism spectrum disorder. And what they noted was that individuals may engage in behavior to bring about the release of endogenous opiates, which give a high that becomes addictive to these patients. So anytime they engage in a self-injurious behavior, the endogenous opiates are released, such as endorphins, and the patient feels good. And that's why they keep engaging in this behavior. Individuals with ASD may have altered sensory thresholds, possibly due to high circulating levels of endorphins, which renders them less sensitive to pain. Opioid antagonists, such as naltrexone, may reduce levels of self-injurious behavior by blocking the individual's high or increasing the individual's sensitivity to pain. So from all these conditions, as you can only imagine, management of self-injurious behaviors is quite complex. The optimal approach to therapies, non-pharmacological and pharmacological, is actually not well defined. Majority of the knowledge from data of individuals is from data of individuals with autism. As you've seen, most of the examples I've quoted are with patients with ASD, rather than other non-specific neurodevelopmental disorders. And this makes it quite complex to manage these patients because we're extrapolating patients who have a varied degree of conditions, and not all of them would have autism. Available assessment measures and objective scales to evaluate for self-injurious behaviors commonly evaluate problem behaviors. They're not specific to self-injurious behaviors. Most of the assessment measures evaluate aggression, irritability, tantrums, and self-injurious behavior rather than self-injurious behaviors specifically, which makes it again a challenge in determining the optimal treatment for these patients. Pharmacotherapy, that is medication, often becomes a necessary part of the treatment plan. So how do you assess and manage a child who presents at your clinic and the mother is saying that this child is banging himself all day, this child is scratching himself? So the first thing that you need to do is get a comprehensive medical history and examination so that you can try and pinpoint the etiology of this self-injurious behavior. And you need to assess the patient's safety, level of functioning, as well as specific behaviors. If the patient is in an unsafe environment or is unsafe to themselves, then this may often warrant an admission. You identify, rule out, and address all contributing factors to behaviors. For example, this child with CP who keeps scratching himself, is he constipated? Is he in pain? Has he or does he have another medical condition that he is trying to communicate, and that is why he's engaging in this behavior? Perform applied behavior analysis and functional behavior assessment, which I will discuss later once you've done your history and your physical exam. The first treatment is usually non-pharmacological management and behavioral interventions. And if this does not work, then you initiate your pharmacological management. So for the non-pharmacological management, we have environmental modifications. So if this child is a risk to themselves, you need to provide protection, remove any dangerous materials such as access to fires, or access to sharp objects like knives, consider use of protective clothing and ensure continuous supervision, such as those engaging in headbanging. You may need to get helmet. Increase predictability in the child's routine and decrease unstructured time. So this child should be engaged throughout the day to avoid the child getting bored, because boredom can sometimes lead to self-injurious behavior. So there should be a timetable from morning to evening, and provide options for preferred activities. So if you know what the child likes, try and engage them in those activities. And use visual communication for those children who are nonverbal. Like you can give them these pictorials where they can, if they're fine, then they can point and say, I'm feeling fine. If they don't like it, they can give you that says, I don't like it. And this usually helps the patient communicate better, and they will not resort to self-injurious behavior as a way of communicating. Applied behavior analysis and functional behavior assessment. So I'll refer to applied behavior analysis as ABA and functional behavior assessment as FBA. ABA is a systematic approach to behavior intervention. You have this patient sitting in front of you who has self-injurious behavior. How do you arrive at the correct management plan for this patient? So usually you do this by functional behavior assessment, which is the most common application of applied behavior analysis. And this usually involves, in this approach, you need to involve everybody who comes into contact with this child, the parents, the primary caregivers, the teachers, so that you can assess and see what is triggering this child to have the self-injurious behavior. So it usually applies the ABC approach, antecedent, what happened before this child engaged in this self-injurious behavior. B is behavior. What was the behavior? And C was consequence. How did the parents react to this self-injurious behavior? Was it a positive reinforcement or was it a negative reinforcement? Assume that the self-injurious behavior is a learned behavior that is maintained to produce a desired effect on the individual. So a behavior that is consistently followed by a pleasant consequence will increase its strength. If Jane knows that every time she scratches herself when the parents want to change the television to another channel, she will keep engaging in this self-injurious behavior. A behavior that is followed by an unpleasant consequence will decrease its strength. An example is when Matthew bites his hand, his parents usually run to his side and give him toys to play with. So this is positive reinforcement. And when Susan's bus pulls up to her house, Susan usually starts hitting her head against the wall. When she is this upset, her parents do not send her to school. So Susan knows that every time the school bus comes and she bangs her head, she can escape going to school. So it's strengthened by avoidance of unpleasant activity. So functional behavior assessment includes procedures such as interviews, informal observations, or functional analysis of self-injurious behavior. There are some objective tools that we can use, but as I mentioned, these objective tools don't just look at the self-injurious behavior, they also look at other things like aggression in the child. There are two scales that are mainly used, what we call the Clinical Global Impression Scale and the Irritability Subscale of the ABC, that is Aberrant Behavior Checklist. So this, for the first one, the CGIS, usually two physicians will rate it, and it's a 7-point scale used to qualify the symptom severity and clinical improvement from baseline. So this is a scale that is used over time. And the ABC checklists, it's usually given to parents or teachers who rate irritability, and it usually has 15 items using a 4-point scale, such as how irritable is this child, how aggressive is this child, and it's usually not specific to self-injurious behavior, as I mentioned. So non-pharmacological management, the American Academy of Pediatricians actually recommends behavior treatment based on the results of a functional behavior assessment. So you've done your FBA by observing the child, by interviewing the child, and they actually say this is the best practice. Unfortunately, there are no guidelines in Africa and specifically in Kenya. It examines environmental aspects warranting change to reduce self-injurious behavior. For example, a child who engages in self-injurious behavior to escape academic demands. And a functional behavior assessment approach would involve delivering escape from the demand on a communication request. For example, this child, if verbal, can be taught to say, "break, please," when they feel that they're being overwhelmed in school. Functional behavior assessment, therefore, would reduce punishment-driven procedures. We know in Africa, most parents would get frustrated if the child is engaging in a self-injurious behavior and resort to actually beating this child, which may actually worsen the self-injurious behavior. So for FBA, teaching function, you need to teach functional communication skills, which can reduce self-injurious behavior. As you can see, using of these pictorial charts, the skills translate to other contexts, and these results are usually maintained over time. So FBA has been proven to be a good approach for management of self-injurious behavior. Often we find that these non-pharmacological therapies fail. So we must resort to pharmacotherapy for self-injurious behavior. As I've said, ABA with FBA is the gold standard. Pharmaceutical approaches can be used as an interim for protection. For example, if the child is very violent, then you must use pharmaceutical approaches. It primarily targets symptoms rather than the mechanism of the disease, leading to perpetuation of self-injurious behavior. What this means is most of the pharmacotherapy available, it just treats the symptom, but it doesn't really treat the underlying disease, which causes the self-injurious behavior. So it's something that long-term will not really cure the self-injurious behavior, but it just reduces. And as it reduces the symptoms, then we should try and implement non-pharmacological approaches. In chronic intractable cases of self-injurious behavior, dual approach is necessary. Unfortunately, majority of the pharmacotherapy that we use is off-label. There are few randomized controlled trials, with majority of the studies being in patients with autism spectrum disorder, with extrapolation to other neurodevelopmental conditions. And this may obviously affect the clinical response. For most clinicians, it's based on clinical judgment and case by case. So when you have a child with self-injurious behavior and you're considering giving certain prescriptions, what must you bear in mind? You must bear in mind the type and severity of self-injurious behavior. As I mentioned, in Lashline Syndrome, it can be quite severe, where you find the patient is actually biting off their lip, or in patients with ASD type 1, it can be less severe. You must consider the child's medical history and developmental age, because these medications have side effects. You must consider the pharmacokinetics, pharmacodynamics of the drug-to-drug interactions. A lot of patients with neurodevelopmental disorders may, for example, be on anti-seizure drugs, drug-to-disease interactions, for example, sedation from polypharmacy if you're giving multiple agents, availability and applicable efficacy and safety data, as well as response to treatment, meaning you must keep evaluating these patients when you initiate them on pharmacotherapy to see if they respond. So once you initiate the drugs, you must monitor these patients. Pharmacotherapy must be methodically monitored for individual response and ongoing rationale for continuation of therapy. This we know can be a challenge in the public setting. For example, in KNH, sometimes you find that you have many patients coming for one clinical visit. You can have up to 60 patients with each of our pediatric neurology visits. And I know it's the same for the psychiatric clinic. And so sometimes you may not be able to monitor them as frequently as you could wish, but monitoring is very important. And when the agent does not demonstrate a clear benefit, please continue the medication. So this is why close monitoring is important. Appropriate therapy alterations must be made based on the patient's response to therapy over the course of ongoing development and changes of clinical status. This patient will grow. The patient will add weight. Some patients may have specific treatments, which will lead to reduction in the self-injurious behavior. So don't just start a patient on a medication like Risperidone and leave it lifelong. You must continue monitoring these patients in your clinic. So the first drugs that I'll discuss is the second generation antipsychotics, which are the most common drug used for self-injurious behavior and the ones that have the most randomized control studies available. So it's commonly used as a first-line medication. Unfortunately, it's largely based on studies from ASD children, as I have mentioned, and this data is extrapolated to other neurodevelopmental disorders. Risperidone and aripiprazole are FDA approved for management of self-injurious behavior, aggression, as well as tantrums in patients with ASD. Significant improvements in the aberrant behavior checklist scores have been shown in patients who use second-generation antipsychotics. Other medications apart from risperidone and aripiprazole that are used include olanzapine and ziprasidone, although these are less used. Risperidone and aripiprazole have the most randomized controlled studies that have been done. And usually they have been used for risperidone, it's been used for patients with other pervasive developmental disorders, such as Rett syndrome. It's been used for patients with Down syndrome, as well as Fragile X syndrome. Aripiprazole has mainly been used for patients with autism spectrum disorder. Now, as you give these two medications, it's very important to monitor for adverse effects. The other day, I was reading an article for patients who have been on long-term risperidone, and it was men who have formed a society to advocate for knowledge on the side effects of risperidone, because it can cause quite severe gynecomastia, which you can imagine can be quite distressing for a male, a teenager who has, large breasts, and maybe he has to go for swimming with his other colleagues, so it can be quite embarrassing for him. Risperidone and aripiprazole can cause marked weight gain, so you must work closely with your dietitian to ensure that these patients are healthy. Risperidone usually cause increased appetite, so these patients will be eating a lot and they can really gain weight. It can cause somnolence, dizziness, so this is important, especially in the teenagers who start driving. It can cause fatigue, drooling, as well as glucose intolerance. So you must monitor your sugars for this patient. Aripiprazole, aside from weight gain, can cause extrapyramidal symptoms such as movement disorders, what we call choreoathetoid disorders, which is dance-like movements, and it can also cause sedation. Olanzapine and ziprasidone do not really have a lot of randomized control trials on their use for neurodevelopmental disorders. Most of them are solitary case reports or a few small studies. They have side effects. Olanzapine can also cause weight gain. It can cause dyslipidemia and increased appetite. Ziprasidone, it's important to do your echo and ECG monitoring because it can cause prolonged QT syndrome. One advantage of ziprasidone over the others is that it's weight neutral and it doesn't cause marked weight gain in these patients. So the strength of the evidence is highest for patients who are using risperidone. Most of the studies have involved ASD. Unfortunately, for the other neurodevelopmental disorders, we don't have many studies, and the same goes for aripiprazole. For olanzapine, the quality of evidence is also low, as is with ziprasidone for patients with self-injurious behavior. For risperidone, start low and go up slowly. Usually you start at around 0.25 milligrams per day and titrate upwards over 2 weeks with a maximum dose of 3 milligrams per kg. For aripiprazole, you start at around 2 milligrams once a day and you go up slowly. So clonidine, aside from your first generation antipsychotics, we also have the use of clonidine. Clonidine is it's a sympathetic antagonist and usually binds to the alpha-2 receptors in the CNS, decreasing CNS outflow in specific regions of the brain. And by decreasing the sympathetic outflow through stimulation of the inhibitory pathways, and in this way, exerting a direct effect on pain, which may be effective in minimizing this overarousal. Remember earlier we mentioned that one of the causes of self-injurious behavior in children with neurodevelopmental disorders can be this overarousal. Usually it's initiated at a dose of about 0.025 milligrams per day and titrated up slowly. It does have adverse effects which we must be cautious of, including transient decrease in alertness and lethargy. The available evidence for its use in self-injurious behavior is lacking, unfortunately. N-acetylcysteine is another drug that is being used more and more in patients with self-injurious behavior. A lot of the times you find that it's used in combination with risperidone, and there are studies that have shown that it does help reduce self-injurious behavior. N-acetylcysteine is an antioxidant and a prodrug of cysteine. It's available locally, like you can find it in Healthy You. One theory for its use related to self-injurious behavior is an increase in excitatory signaling due to exaggerated glutagic transmission. So glutamate is an excitatory neurotransmitter, meaning it causes excessive firing of the neurons in the brain. And N-acetylcysteine has been shown to reduce this glutamate release from the brain, and in this way, reducing inflammation in the brain and through the glutamate cysteine antiporter. And in this way, it is thought to reduce self-injurious behavior. However, use of N-acetylcysteine in self-injurious behavior is off-label and is not yet FDA approved. Amantadine and riluzole are other two drugs that usually reduce glutamate release, which I've said is an excitatory neurotransmitter in the brain. Amantadine works in a glutamate receptor called NMDA. It acts as an antagonist, while riluzole acts in a glutamate receptor called AMPA, also as an antagonist. Riluzole and amantadine have demonstrated clinical benefit in patients with psychiatric disorders, and it may be promising in treatment of patients with self-injurious behavior, although its use remains off-label. So pharmacotherapy affecting endogenous opioid systems and pain pathways is also something that's under exploration. As I mentioned, patients with self-injurious behavior sometimes engage in this in order to cause release of the endorphins, which cause a high in these patients. So the exact relationship between pain and self-injurious behavior, however, remains unclear. And as I've mentioned, the endogenous opioid system is thought to play a role. Pharmacotherapy that targets pain processing and opioid binding may help in self-injurious behavior. An example of this is the use of Naltrexone. It's a pure opioid antagonist that exhibits high affinity for opioid binding sites. Its role in self-injurious behavior evolved from the theory that self-injurious behavior stimulates the release of endogenous endorphins, as I've mentioned, which may drive some of the observed repetitive behavior patterns. Its use in self-injurious behavior is minimal and conflicting. There are few case reports that have shown that it does show an improvement for patients with self-injurious behavior. Topical anesthetics have also been used in some case studies that I looked at in the treatment of self-injurious behavior. Usually they will act by inhibiting ion influx required for conduction of impulses, and they do this by stabilizing the neuronal membrane. Basically, they prevent firing of action potentials, which usually cause pain. And the ability to block skin sensation may be useful in self-injurious behavior, which are hypothesized to be due to automatic reinforcement, defined as direct stimulation independent of environmental effects. The use of lignocaine has been tried, but as you can imagine, this can only be used in a very small portion of the patient with self-injurious behavior. Use in patients with self-injurious behavior is not routinely recommended and is restricted to select cases where the self-injurious behavior is limited to a small and distinct topical area. Antiepileptics and mood stabilizers have also been used in some patients with self-injurious behavior, and theoretical benefit is of decreasing irritability in self-injurious behavior. However, data is lacking to support their use. There's a study that was done by Shapira et al. In 2009, and they showed that topiramate has been reported to be effective in an 8-week open-label trial for 3 adult patients with Prader-Willi syndrome, as evidenced by improvements in skin picking in all the patients following initiation of topiramate. Other anti-seizure drugs that have been used for self-injurious behavior include valproate, oscarbazepine, levetiracetam, and lamotrigine. However, most of them are used as mood stabilizers rather than being used directly for the management of self-injurious behavior. Other agents that are used include allopurinol, which specifically is used for Lashline Syndrome, where these patients usually present with hyperuricemia. And once you reduce the uric acid levels, these patients have less self-injurious behavior. Vitamin B12 has also been tried in some studies, and it's a cofactor of antioxidants and stimulates the regeneration of methionine. Physiological abnormalities such as oxidative stress and inflammation have been associated with symptoms of ASD. I know a few parents who use the vitamin B12 off-label, and they have reported an improvement in irritability for patients who demonstrate self-injurious behavior. So in conclusion, as you can imagine, self-injurious behavior, it's quite complex to manage. There's no evidence-based guidelines currently existing, and the approach is multifactorial and multidisciplinary. You need to involve your psychiatrist, your psychologist, the family, the school, the neurologist, the developmental specialist, the endocrine specialist, the pharmacy, all in the management of this behavior. And the best approach is to resolve contributing factors. If the child is constipated, treat this. If the child has a loose tooth that's causing dental pain, take it out. Non-pharmacological intervention is the best approach, applied behavior therapy, and pharmacological therapy is based on up-to-date available evidence, clinical judgment on a case-by-case basis, and ongoing monitoring of treatment effects is necessary in this patient. Thank you. I'm now open to questions, but before I do that, I'll let Dr. Umulker, who's a developmental specialist, to just give us a comment. Dr. Umul?
I think
meanwhile,
Dr. Hassan has dropped off.
Okay, then I'm open to questions and comments. Judy?
Wow, thank you very, very much for that very broad, journey through the self-injurious behaviors. And you have really elaborated right from the causes and going through the impact. We've seen how these SIBs impact the patients, the healthcare workers, as well as the caregivers, and on to the management. There are some few questions. Maybe I would just like to raise them and just to start the conversation. So Abigail has asked, what causes intermittent leg shaking? Maybe I'll just ask the three of them that are there. And then second, Maurice has asked, the beating culture from parents should reduce intensity of SIBs and not reinforce as a reward. So should we encourage this intervention? And then there's one last question. What is the relationship between SIBs and Savant syndrome as seen in ASD? I don't know whether you've had them clear, the three questions. You could
yes.
tackle them.
Okay, so I can start with the relationship between self-injurious behavior and Savant syndrome commonly seen in ASD. So Savant syndrome is usually just when patients with ASD have a high IQ, and it doesn't really have a direct correlation with self-injurious behavior. However, autism spectrum disorder in itself does have a correlation with self-injurious behavior. And we know that autism is a spectrum ranging from the mild form to the more severe phenotype. And patients who usually have the more severe phenotype are the ones who are more likely to demonstrate the self-injurious behavior. Those patients who have a high IQ, such as the old classification of Asperger's syndrome, tend to really have less of the severe phenotype, and they're less likely to demonstrate self-injurious behavior. And then on the beating culture among Kenyan parents should reduce intensity of self-injurious behavior and not reinforce as reward. Should we encourage this intervention? Well, this is quite a loaded question about the beating culture. I think in the African culture, a lot of us use the spare the rod, spoil the child kind of principle in raising our children. But I think we must bear in mind the clinical condition of the child. Children with neurodevelopmental disorders often engage in self-injurious behavior, not as a way of acting out, but as part of the pathophysiology of their condition. So punishing these children will really not impact them in a positive way. So I would discourage it if you have, your child with whatever sort of neurodevelopmental disorder, it's cerebral palsy or autism spectrum disorder, engaging in beating them. That sometimes can actually cause a negative reinforcement or a positive reinforcement on the baby, on the child. Where some children, if you beat them, they may actually engage more in this self-injurious behavior because in a way they feel like that is the way of communicating. A lot of these patients are usually nonverbal, so we should stick to using guidelines that are well tested and have randomized control trials that have been shown to work in these particular patients. And that usually is what I discussed on the functional behavior assessment, where you look at the environment of the child and try and put in interventions that don't depend on punishment, but interventions that can be long-lasting and help alleviate these self-injurious behaviors, because it can be quite frustrating to the primary caregiver if this behavior continues for a long time.
Lucia, I'm back.
Yeah. Okay.
Just to add on that point, just to add on that point as well, because they have really high sensory thresholds. You end up beating and you don't even get the desired outcome. So instead of getting the desired outcome, they end up acting that at even worse levels and higher levels. So it's just not recommended. It's not the best alternative at all.
Yeah. And then okay, yes.
Then sorry, I got off the net, but thank you for the lovely presentation. But my only emphasis would be on the family-centered approach, because as Lucia has already mentioned, then the cornerstone is the ABCs of behavior. And we can't do the ABCs of behavior as healthcare workers individually. We've got to have the family on board. So you empower the families with information and establish collaboration with them so that you actually end up addressing the behavior, because they spend most of the time with the child. So they're better placed to know the antecedents of this behavior and be able to model the desired behavior. And they're the ones who are going to keep reinforcing or positively or negatively when it comes to a certain desired outcome. And these are the children who we think are very spoiled. Parents usually are very embarrassed because they are thought to be bad parents, because this behavior reflects on the parents like in a negative manner, in a negative light. So these parents need a lot of support. So we need to really collaborate with them and empower them. And actually family-centered approach around behavioral problems has been shown to have better outcomes. The family is less stressed and more involved. And then we end up having less conflict between us and the family members. So, and it's a very complex thing to deal with, and it's very individualized, starting from the point of what is the context of this child, like what is their developmental level, so that you know at what level are you going to engage, what are the strengths of this child who's got a neurodevelopmental disorder, so that you know then what are the approaches you're going to recommend in modeling a certain behavior and what kind of reinforcements that you're going to advise. Then I think we need to really appreciate that families could have preferences and choices. Sometimes people do not want certain behavioral modification patterns that we could recommend. Some families are going to be against treatments, pharmacological interventions. So that's also something that we need to take into consideration. And then of course, as Lucia said, behavior is a means of communication, and then empowering these children with a mode of communication makes their needs be met in a safer manner. And I think this is something that we need to work on, especially in Kenya, because I think the non-verbals, the children who are non-verbal really fall in the cracks. So they end up getting very frustrated, and then this will fuel into the self-injurious behavior. So I think it's something that we need to work on as healthcare workers, look at alternatives of communication for the non-verbal children. Are we going to use argumentative alternative communication? Dr. Omolo mentioned something about the pictorial cards that we could use, that like the picture exchange communication systems. Something that I've seen in South Africa that is really working for the children who are autistic is also markatons. So I think maybe that's something that we could think of doing as well and introducing in Kenya as well. Then I think support groups. Now it's already, there's not so much awareness about autism, leave alone or neurodevelopmental disorders, and then leave alone a parent who's got a child who's got self-injurious behavior. So they need lots of support. So maybe KNH being a really big pool where we see a variety of cases and patients, maybe starting support groups for these parents and putting them together so that they could share lived experiences, and encouraging each other would actually make a greater impact and have better outcomes. Yeah, thank you very much.
Thank you, Omol, for that. So just to also lump some of the other questions, one person is asking if there are forms of self-injurious behavior that are hereditary. Well, there are forms of there are certain neurodevelopmental conditions that are hereditary, as I had alluded to, such as patients with the Fragile X syndrome, and even autism has been shown to occur in families, as well as some of the other conditions that I had mentioned. And then there's also another question that asks, up to what age does self-injurious behavior affect children? So as I mentioned, it can occur as young, it can begin as young as 6 months of life, and it can actually be lifelong, which can be quite frustrating for the primary caregivers. And that is why it's important for us, especially in the Kenyan society, to begin implementing methods that can help tackle this very challenging problem for parents and the children themselves. Then there's also a question on the efficacy of stem cell therapy in autism spectrum disorder. I don't know, Dr. Hassan, if you want to comment on that.
There's a lot of work that is still going on in that area, but then generally, what is against that is that autism is not a neurodegenerative disorder per se. So there's not been shown so much benefit in that, and the studies that have looked at stem cell, they've always had other alternatives, like they've got therapy along with that. So we don't have a clear study that just took autistic children and did stem cell transplant and looked at the outcomes. So there isn't very clear data on that. So it's something that some recommend and some are against. Yeah. A lot of work that needs to still, yeah.
Thank you. There's also a question on intermittent leg shaking. I think that's out of scope of this lecture, but intermittent leg shaking can occur from various causes, from tremors to alcohol use to anxiety to restless leg syndrome. So such a patient would usually require a thorough workup to try and arrive at the etiology of that. I don't know, Judy, if you'd like to comment on the part of psychologists and what you do when you are evaluating a family that presents with a child with self-injurious behavior.
Yeah, thank you very much. And actually, just to appreciate that it's very important to have a multidisciplinary approach. I see here, for example, the caregivers who come in with the children with these NDDs, are going through a lot of psychological, because these traumatic experiences that and so one of the ways
Sorry, Judy, you're breaking.
Especially from the psychological point of view is to also evaluate the caregiver and find out where they are in their space in caregiving and address their issues. Okay, sorry, I think my internet is unstable. Earlier, this NDDs also are there that are brought to the clinic, have the caregivers evaluated for psychological distress and their issues addressed so that they can undergo in, and the best approach is to think about support groups. I think that is with caregivers so that they can have their experiences. I think I wanted to ask, even as reflecting on how we can intervene from a multidisciplinary, also multi-sectorial approach, is within the school systems, because there is integration of children who have different abilities within the normal school system, and there are provisions for special units within normal schools. I don't know whether maybe you can talk a little bit about the extent to which teachers and parents are using this and how well how effective has it been maybe so far? Thank you. Did you hear the question?
No, I didn't hear. You were breaking. Sorry, we lost you, Judy.
Are you hearing now? Is it consistent?
Yes, yes.
It's now consistent. Yeah, maybe you can just share briefly how the use of the functional behavioral assessments by parents and perhaps teachers has been, and how effective has it been?
Yeah. So applied behavior analysis and FBA, in truth, is something that's still a growing field in Kenya. I think there are about maybe 5 or 6 ABA specialists in Kenya. So a lot of the times we have to use modified forms, and a lot of times you'll find that this is carried out by maybe the occupational therapists, the speech therapists, the developmental specialists, or even the neurologists who try and somehow make a modified form of ABA, because ABA is very expensive therapy. And a lot of the ones that we have in Kenya are trained abroad. It is available, but it may not be reachable to all Kenyans. But I think as we're getting more and more ABA specialists, the cost is going down. I know we have some in Aga Khan. We have Dr. Alex Bosiri's wife is also an ABA specialist. We have some in many other private hospitals. I think also Gertrude's has one. Unfortunately, in the public sector, we don't have that, but hopefully that's something that KNH can look at. So most of the time, the functional behavior assessment in KNH, for example, would be carried out by your OT specialists, which would be modification. So this FBA would usually, as I mentioned, usually there's some objective tools that you can use, first of all, to just classify the patient and how severe they are, like your aberrant behavior checklist, which involves a checklist that you give to the teachers, to the parents, or even to other people in the household, where they just try and rate so that you can see the severity of the symptoms. And then usually also for these patients, you need to conduct prolonged interviews, usually over several days, where the patient comes into your office and you kind of just see them in their normal space. Or in the US, the ABA specialists actually usually go home and observe the child in their normal space so that they can make an assessment. And then they even assess, let's say a child is engaging in some form of self-injurious behavior. They assess the child's in like what self-injury, the ABC approach, as I mentioned, what was the preceding thing, the antecedent event, and then what behavior did the child perform, and how did the parent react to this particular situation. And from this, usually you come up with a sort of plan where you teach the parents how to react to certain situations. For example, you may find if parents do certain things, this can actually reinforce the behavior of this child. So you teach different strategies. It might be time out. It might be a different approach. It might be teaching the child, like, for example, if the child is about to engage in a certain behavior, you can say quiet hands. So just doing positive and negative reinforcement to bring about the behaviors that are positive and to take away the behaviors that are negative. But as I mentioned, this is still a growing field in Kenya, but we do have very excellent ABA specialists who are implementing this in our setting.
Okay, thank you very much, Dr. Ari. There are some other questions in the chat. Maybe I'll read 3 by 3. So there's one question here. Please comment on the audio integrative therapy for managing sound sensory issues. And the second question is, how else can NAC be used other than SIB? Maybe you answer the 2 first. I go to this the chat.
Okay, thank you. I can see the questions also. So NSC has also been used in other psychiatric and neurodevelopmental conditions just to help with aggression. But I'd like to emphasize that this is an off-label use and it has not been FDA approved for treatment of either self-injurious behavior or aggression. So it's just a few case control studies that have been done, and they have demonstrated that there is a positive effect on aggression and tantrums and self-injurious behavior, but it is off-label use. Then the other question was about audio integrated therapy. I think maybe I'll let Dr. Umul Care or an OT answer this. I don't have much information concerning this, but I do know that it has been tried in patients who have overstimulation or sensory integration issues to try and just kind of help them in the management of these sensory integration issues. There's also a comment about some of these conditions like Bell syndrome, maybe the Rett syndrome, are generally associated with the docile behavior. That's very true. So a lot of these neurodevelopmental disorders, as I mentioned, it's a spectrum. Not all patients with ASD will have self-injurious behavior. Not all patients with Rett syndrome will have self-injurious behavior. And Prader-Willi syndrome, we also have the Angelman syndrome, which is the opposite of Prader-Willi syndrome. It's usually caused by mutations in the maternal as opposed to the paternal for Prader-Willi. So patients with Angelman syndrome tend to have a very happy demeanor. They're happy, they're laughing all the time. So it's a spectrum, and so it is important to evaluate your child and just see where on this spectrum that the child lies. Then there's a question concerning the difference between ASD and ADHD. I can give that to Dr. Umul Care to answer.
Okay, starting with the first one about audio integrative therapy, there is contradictory evidence scientifically, but some show that there is benefit. Generally, the concept of sensory integration is still used to help with sensory regulation and modulation. So it does work in some cases. So it's a case by case, again, as we said, individualized and depending on the context and what the trigger is. So sometimes it could work. There is a role and there's been successes, but there is really no shoe that fits everything, especially when it comes to neurodevelopmental disorders. Sometimes it works. It's mostly been studied amongst children who've got autism, and some have benefited from it and some do not show much improvement. So it depends. but there is some benefit of general sensory integration as a modality of dealing with autism. The same way that applied behavioral analysis is a bit controversial. Some people say that maybe using the teach approach, which is treatment education of autistic related communication and handicapped for children, does work. So it does depend, but I think it's a starting point. If that's all we have, then it's fine. We could start off and build on that. But then I think the current approach is just looking at the strengths of the child and the challenges and seeing how to best address them. Yeah. Then the difference between autism and ADHD, there's a whole lot of difference, and we could talk about that a whole other session. But for starters, there is a clear DSM-5 criteria for autism and a clear DSM-5 criteria for ADHD, where there is excessive impulsivity with ADHD, lots of hyperactivity. The child is very busy and all over the place in simple terms. Yes, but there are clear diagnostic criteria that have to be met as per the DSM-5 criteria for both. Yes.
Thank you, Dr. Hassan. I think you've also answered one of the questions that was asking about the studies behind the use of ABA, and as she has said that some centers do consider it to be a controversial mode of treatment. There's also a question concerning how early can bipolar mood disorder be diagnosed in kids, because I have seen an adult patient with bipolar with dermatillomania when in manic phase. Well, I think that's beyond the scope of this, but if you are suspecting a child, it can be diagnosed in children. So usually you need to go to a psychiatrist so that they can see if the child fits in the DSM criteria for bipolar mood disorder for the correct diagnosis to be made. But yes, it can be diagnosed in children. I think that's it for the questions. I'm not seeing any more.
I think I'm just seeing one. There's one that's, yes. We did AIT therapy in London in 2006 for my son, ASD, now 22, and it is a game changer. As you say, it varies from child to child. That's a comment.
Thank you for that comment.
Question. Yes, there was a question earlier. Comment on conditions like Bell syndrome are generally associated with pleasant docile behavior, and only a small number may be aggressive.
I think I answered that question.
Okay, that was before. Thanks.
Yeah.
I think there are no more questions in the chat. So I think you're getting a lot of applauses here. Thank you very much, Dr. Lucia and Dr. Hassan, for really expounding very much on these SIBs, and also giving us a challenge that in as much we may not have a lot of resources, like high income countries in managing these SIBs, we could start where we are with what we have available. And as you had said earlier, that it is necessary to have support groups so that families may be able to understand their children better and be able to give appropriate encouragement along this journey. Because you have said that some of these conditions are lifelong. So thank you very much also to the audience for the comments and the questions. And together we have a great part in managing this condition. Thank you and goodbye.
Thank you.
Okay, thank you, Willy, and thank you, Dr. Amolo and Dr. Hassan, for this quite informative session. I was wondering whether we can, if we can get you once more for maybe we can plan another session in regards to what we've been talking about today and the questions that were outside of this scope. Maybe we can, if it's possible, we can organize a session like that in the near future.
Sure, with pleasure.
Definitely. Thank you.
All right. Thank you. Thank you for your time. Also, thank you to our participants for joining today. For PPB participants, please note that the session will be uploaded and you will be sent an email notification of the same once it is ready for subscription. For the others, we will be sending the CPDs via email. KMPDC, they will be uploaded automatically to your ICPD portal, together with the COC, clinical officers as well. Thank you once again. Do have a wonderful evening.